hopefully you guys can see my screen now. Okay. You all see my screen? Yeah?
Yes.
Okay, thank you. Okay, so we're going to start with respiratory. So chapter 40 is respiratory dysfunction. Okay, so respiratory infections, they're one of the most common childhood illness causes, usually viral, but can also be bacterial, okay? They can involve the upper respiratory tract or the lower respiratory tract. So what's involved in the upper respiratory tract is the oronasal pharynx, the pharynx in the back of the throat, the epiglottis, the trachea, okay? And then the lower respiratory tract, that's going to be more your lower trachea, your bronchioles, your bronchi, alveoli, and your lungs. Okay. Okay. So like I said, they can be caused from viruses typically, but also can be caused from bacteria. So the most common cause of upper respiratory illness in children is RSV, so respiratory syncytial virus. This is the big scary one that you guys hear about. The most common cause of hospitalization in kids less than 2 is RSV. It's also a really common cause of pneumonia. Kids with RSV, especially infants, they're more likely to have those apneic spells where they have pauses in their breathing. They're not going to be eating as well, so dehydration can be a struggle because they're not eating because they're working so hard just to breathe. Okay. Older kiddos, RSV is going to look more kind of like a common cold, so cough, congestion. But RSV in older kiddos, like I said, if it causes pneumonia, it can really make them sick as well. Okay. Bacterial causes of upper respiratory illnesses, strep, group A, beta hemolytic strep. Staphylococcus can be a cause. Haemophilus influenzae, which is one of the reasons why we vaccinate for HIB or Haemophilus influenza. It used to be a really common cause of bacterial meningitis as well. So that's an important one to know. Chlamydia trachomatis, that's another bacteria that commonly causes pneumonia. And then mycoplasma, which is also another cause of pneumonia. Okay, so when you're less than 3 months, you have your maternal antibodies still from when you were in utero. 3 to 6 months is when you start having that increased risk for infection exposure. Think about it, that's when most kids are going into the daycare setting. So, you know, they're getting just more exposures, and that those maternal antibodies are starting to wane. If babies are still being breastfed, then they can retain some of those maternal antibodies until about 6 months of age. After that, most of what they had in utero has kind of waned. Okay. Toddlers and preschoolers, they're getting a ton of viral infections. Maybe they were in preschool, or excuse me, daycare prior to starting preschool, but now they're in preschool with a different group of children. So the rate of infection starts to increase at this age group. Mycoplasma pneumonia and group A beta hemolytic strep are more common in those kids over 5. And then as kids get older, just like with adults, they become, they start to have more immunity to these illnesses. So they might get RSV, but they won't be as sick as they would have been when they were, you know, a year and they had RSV. Okay, another common illness is otitis media. So this is an ear infection. This is very common in childhood because their eustachian tube is so narrow. So what happens is their eustachian tube's really narrow, so that fluid just kind of accumulates in that ear. Kids are also a lot more congested typically than adults. So it's a lot more likely to kind of that fluid to hang out in their behind their eardrum because of that eustachian tube being more narrow. Okay, it's diagnosed on exam. Okay, so using an otoscope, a provider looks in their ear and they look at that fluid. And if there's redness of their TM and it's bulging or it's dull, all of those sorts of things cause a diagnosis of otitis media or ear infection. Okay, when you think of otitis media, it's the middle ear. Okay, so it's behind that tympanic membrane, which is right here. Okay. If you think of like swimmer's ear, when you get from swimming, that's your external ear that gets infected. Okay, so we're talking back behind the TM, the tympanic membrane in that middle ear. Okay, for an otitis media. Okay, so these do need treated with antibiotics. Okay, usually amoxicillin is the first choice if the child does not have a penicillin allergy. Okay. If they're less than 2, then you absolutely need to do an antibiotic if they have an infection. If they are 2 or older, you can do kind of a watch and wait, tell parents to keep an eye on the kiddo for the next couple of days. The provider will send in an antibiotic for parents to pick up if they feel that their kiddo's worsening over the next couple of days, then they should pick that antibiotic up. But a lot of times ear infections can be viral, but the risk in kids less than 2, of course, is speech development and hearing effects. So that's why we want to treat those kids right away. Sometimes kids have too many ear infections back to back, or ear infections that never resolve because they just have that chronic fluid due to their eustachian tube being narrowed. Then these kids have to have laryngotomy tube placement or ear tubes placed. Okay. Nursing care for otitis media, of course, talking with the parents about completing their antibiotic as prescribed and doing Tylenol or Motrin if needed. At what age can kids start Motrin again? Anyone just shout it out? Do we remember? Starting at 6 months, kids can have Motrin. Before that, it's just Tylenol, okay? But doing Tylenol and Motrin as needed for pain with these ear infections, sometimes they can be very painful and really affect the kiddo's sleep schedule and daily life. So that is the types of things that you would be doing as a nurse. Of course, surgically, if the kiddo has surgery and you're in surgery, with this kiddo, managing them like any other intraoperative kiddo. So vitals, things like that. Okay, and then preventing recurrence by educating the parent to complete their antibiotics and return if they're not getting better. The other thing that's important nursing care wise is telling parents if kids are less than 2, they need to come back usually within about a month after being treated for the ear infection to make sure that that ear infection totally went away. Okay. Like I talked about, our airways are more narrow and shorter usually in kids than adults. So you can see right here, eustachian tube pathway is a lot shorter and it's more narrow, and it goes, from the nasal cavity to the ear, the inner ear. So this kind of sets up the perfect storm when kids are often snotty and congested, that it kind of backs up into that middle ear in comparison to the adults who have a much more wide and lengthy eustachian tube. Okay. Manifestations of viral illness, or excuse me, of respiratory illnesses, usually fever, not always. A lot of times kids will have vomiting or abdominal pain or diarrhea, cough, sore throat, congestion, of course, those kind of common cold symptoms. Younger kids usually, so like infants, usually you'll see decreases in their eating and their fluid intake. If they're having something like a sore throat or cough or congestion or respiratory distress, before you see, you know, progression to kind of what you would see in a older kiddo of, you know, the classic cough and them saying that their throat hurts or their ears hurt. Okay. You can see significant headaches. You can see meningism, which can be signs of, you know, like a stiff neck or kind of limited range of motion of their neck pain, or if they're looking down, they have severe headache along with fever. Those are concerning signs for meningitis. Respiratory sounds with respiratory illnesses can vary depending on what sort of illness the kiddo's having. So if they're an asthma kiddo, you know, you're going to hear more expiratory wheezing. If they're just a common cold kiddo, you know, their lungs might sound just a little bit coarse, like they need to cough and kind of clear that gunk out of their lungs. Or, you know, they might have really wet, gunky sounding lungs, which then would signify more of a pneumonia illness. Some kids with upper respiratory stuff, you know, upper respiratory is going to affect more sore throat, nasal passages, top of trachea. So you're not going to hear the lung effects like you would in a kid with a lower respiratory illness. Okay. Managing care for children with respiratory illnesses, of course, promoting rest and comfort so that way they can get over the illness, reducing the spread of infection or preventing the spread of infection by telling parents to keep their kiddos home if they have a fever or vomiting or diarrhea or any other sort of infection concerns. Reducing their temperature so that way they can feel more comfortable. A lot of times with these colds, kids can be pretty achy. So not only in helping their fever, but can also help their overall body to feel better by reducing their temp. Okay. Promoting hydration and nutrition. And then, of course, managing their respiratory effort. Okay. Supporting parents and reassuring parents. It's really difficult as a parent to have a kiddo with a viral illness, be told it's viral and there's really nothing you can do about it. So you guys as nursing staff need to really help parents try to get through that and reassure them that their kiddo should be getting better. Okay, mononucleosis. So this is caused by Epstein-Barr virus most commonly, which kind of mimics a herpes-like virus. So kids usually start with extreme fatigue, fevers for a couple days, sore throat, usually a few days to weeks before the fatigue kind of comes along. Swollen lymph nodes in the neck, usually, sometimes the armpits, swollen liver, spleen, and rash. Okay. Monospot testing is what is needed, which is a blood test that tells you if they've been exposed to Epstein-Barr virus and if it's a current infection or if it was a prior infection. It's viral, so viral kind of management. Now, the big thing with mono is these kids have to stay out of contact sports because of their liver, their hepatomegaly and their splenomegaly. Okay, so their enlarged liver and their enlarged spleens. So these kids have to stay out of contact sports for usually 6 weeks. Now, nursing care wise, no exercise for these kids for 3 weeks. Okay. So no contact sports for 6 weeks. And then the first 3 weeks, no exercise. These kids will need to be doing like half day or partial days of school, usually because they're that fatigued. They just can't even make it through a whole school day. Okay. Bronchitis, also known as tracheobronchitis. So this is inflammation of the trachea and the bronchi, which are those bigger airways. Okay. Most common from a virus, that dry, hacky, not productive cough. Okay. These are the kids that are coughing that dry, yucky cough all night. Usually no fever. Okay. Cough suppressants, you do not want to do cough suppressants in kids, because what happens is if parents are doing cough suppressants, they're not coughing that gunk up. And what happens then more likely is that these kids will get pneumonia. The other piece with cough suppressants or cough medication that's over the counter is a lot of times it contains Tylenol or Motrin. Plus then parents are also giving them Tylenol or Motrin because they're not feeling well. So you run the risk of getting too much and overdosing on Tylenol or Motrin, or overdosing on the cough medication, because some of them are every 4 hours, or some of them are every 12 hours, some of them are, every 6. So it's hard for parents to keep track of that. Okay. Humidifier by their bedside. Honey, if they're over what age can kids have honey?
1 year.
1 year. Yep, exactly. So honey is helpful over the age of 1 for cough. That's probably actually more helpful than 95% of the cough suppressants that are over the counter. Okay. They can also do Vicks to their chest. And then of course, Tylenol or Motrin if they're feeling miserable. Okay, croup. Okay, croup is a syndrome or kind of an effect. Okay, that's that dry, barky, like a seal cough, inspiratory stridor. So they sound like they have a really narrow airway. You'll kind of hear them do that sort of noise. Okay, some croup is minor and some is more significant. Okay, it usually happens with kiddos with parainfluenza virus or Haemophilus influenza type B bacteria. Okay. Croup can cause narrowing of the larynx, the trachea, and the bronchi. Okay. It can involve also the epiglottis, which is life-threatening. Okay. So croup, you'll see it as laryngotracheobronchitis or tracheitis. That's all croup. Okay. All right. So acute laryngotracheobronchitis, which is inflammation of the larynx, trachea, and bronchi. This is the most common form of croup, usually less than 5. Like I said, most common causes are RSV, you can see, but usually parainfluenza virus, group B strep, not group B strep, strep pneumoniae, which we vaccinate for, okay? And then mycoplasma pneumoniae. Sometimes flu A and flu B can cause croup as well. Okay. Like I said, tight barking like a seal cough, suprasternal retraction. So you'll see retractions kind of over the sternum. So right here, usually is where you see those retractions. Worsening hypoxia as respiratory distress progresses, and it can eventually progress to respiratory acidosis and respiratory failure. Okay, and inspiratory stridor. Okay. Okay, acute epiglottitis. This is what I said is a medical emergency. what you'll see in kids is agitation, drooling. They're not going to be able to spontaneously cough. They're going to have muffled voice. They're going to come into your clinic or your office or your ER, and they're going to be tripoded. So they're going to be leaning forward with their arms on their hands on their knees, trying to get air in any way possible, because they physically cannot get air in because their epiglottis is swelling so much. Okay. You're going to see suprasternal retractions, substernal retractions. So in between those rib bones, you're going to see retractions. It's going to start, though, initially as inspiratory stridor, similar to croup, mild hypoxia, and then it will progress, eventually to full occlusion of that airway. Okay. So what's going to need to happen is this kid needs to be intubated right away, or if they're unable to be successfully intubated, then they're going to get a tracheostomy for a period of time. These kids will also get steroids and racemic epinephrine, which is inhaled epi, okay, through a nebulizer treatment. Okay. But your biggest thing with epiglottitis is making sure that they maintain their airway, and you guys, someone gets them intubated right away, so that way they don't lose their airway. Okay. Okay. RSV, or respiratory syncytial virus, also known as bronchiolitis. So this is the inflammation of the bronchioles. So those really tiny airways. What happens is they get really gunky secretions that start to block up those tiny airways, and then it increases their work of breathing. Most common from about October 1st through March or April. In most places, it kind of depends on where at in the United States or where out in the world you are, kind of when your season starts, but most commonly October through April. Okay. It's diagnosed. They can do a respiratory film array panel, or other testing up the nose to diagnose RSV. It's viral, so management wise is managing their work of breathing, making sure they're staying hydrated. Tylenol or ibuprofen, if they can have ibuprofen, is kind of how you manage these kiddos. Suctioning is also a very important part of RSV, and any, honestly, respiratory illness for kids, especially infants, because they're obligate nasal breathers. So if their nose is gunked up with something, they can't get adequate air into their lungs. Okay, so talking with parents about making sure that they're suctioning these kiddos before, they eat or before bed, to make sure that they're maintaining their airway. Prevention or prophylaxis of RSV, Synagis is getting ready to be phased out, but it is still in your book as a preventative injection that you can do. It's monoclonal antibodies. That's why you see that MAB, that means monoclonal antibody. So it's antibodies to RSV. They're short-term antibodies, so they just last coverage-wise about a month. So kids that were high risk for RSV complications, like being born before 35 weeks, or having congenital heart defects or congenital lung defects, these kids would qualify for Synagis, and they would have to come in every month from October 1st through April 1st to get an injection. Now there is Fortis. You might have seen an advertisement potentially for that, or Nursinimab is the other name. This is also a monoclonal antibody. This lasts their entire season though, so they just get one dose and it lasts them their entire first RSV season coverage wise. So if the thought is with monoclonal antibodies, if they get exposed to RSV, their body recognizes that by mounting an immune response with the antibodies, and hopefully then they don't have to be hospitalized because of severe illness. Okay. So Synagis will actually go away at the end of this year, and Nursinimab will take over. That way these kiddos don't have to get poked so often. And Nursinimab has been so helpful in reducing the amount of hospitalizations last season with RSV. That it's recommended across the board to any baby under the age of 8 months in their first RSV season. Okay. Nursing care with RSV, you're going to do, respiratory support. So these kiddos will probably be on oxygen if they're in the hospital. If they're not in the hospital and you're sending the kiddos home, making sure parents know how to suction adequately with saline, Tylenol, Motrin, humidifier by the bedside. All of that is helpful and kind of things for parents to watch for if their kiddos starting to have respiratory distress when they need to come back to the ER. Tonsillectomy. So this happens usually from chronic inflamed tonsils, typically related to group A beta hemolytic strep, so strep throat. So some important things to consider after having had a tonsillectomy is avoiding any highly seasoned foods or irritating foods, like hard foods that could scrape the back of the throat where those scabs are from where they cauterize the tonsils off. If kids start swallowing often after they've had a tonsillectomy, that would be a concerning finding. They would need to go straight to the ER if that happens, because these kids are definitely at risk for bleeds. And they can bleed very quickly and in large amounts after these tonsils are removed. So making sure that you let parents know if they notice their kiddo swallowing a lot, then that they need to be going to the ER. Okay. Of course, fever, severe earache, sometimes ear pain, can kind of be a complaint that you hear from kids after they've had their tonsils out. So having them chew gum, but if their ear pain's severe, they're having high fever, they're having cough. If they start having cough after having a tonsillectomy, that's concerning too, because sometimes they can cough hard enough that they can kind of break off those scabs as well. Okay. So you want to make sure you're teaching parents to not allow their kiddos to do this, like putting sharp objects in their mouth, straws, chips, that can scrape in the back of the throat, all of those sort of things. Avoid those for at least a couple weeks. Okay. Usually recovery-wise, it's 1 to 2 weeks. If they are really diligent about following their post-operative instructions, usually they're feeling much better within a week and can start eating kind of some more typical foods. Okay. Pneumonia. So multiple different kinds of pneumonia. Some, like I said, can be viral cause, so RSV pneumonia. Some can be bacterial cause. Like chlamydia, forms of pneumonia. They can be pneumonia, if it's untreated, can lead to sepsis. The other thing too is, aspiration pneumonia. So if you're inhaling, oh gosh. Oh my goodness, I'm totally blanking on the, incense. If people are like burning incense or having like those scentsy pots that aerosolize the liquids in the sense that sometimes can cause pneumonia in kids. So just being aware and educating parents about that as well. Pneumonia wise, of course, if it's bacterial, and you can't always tell based on the x-ray. So a lot of times the pneumonia is treated as bacterial by giving an antibiotic. So making sure, once again, you're talking with parents about being sure that these kids complete their antibiotics. Of course, they're going to be coughing. They're probably going to have rib pain from coughing so much. So doing Tylenol or ibuprofen, honey for cough, humidifier by their bedside, things like that can be helpful with pneumonia. Okay. Kind of already talked about this. So the strep pneumonia vaccine that we talked about a couple weeks ago being given in infants, that was developed because of the concerns of pneumonia. So that is streptococcal pneumonia, is what is covered in that vaccine. And now there's 20 of the 23 strains of strep pneumonia that we're aware of that is covered by that vaccination. And pneumonia essentially is inflammation of the lower lobes, typically of the lower lobes of the lungs. What happens is that bronchial, which is the narrow airway in the lung, becomes inflamed, and then the alveoli kind of accumulate with fluid, mucus, essentially. Okay. Okay, aspiration pneumonia. This is what we talked about briefly with, with the like incense, the in the Scentsy pots and things. Okay. So it used to be common that talcum powder was used. So baby powder used to be made from talcum. And parents would very routinely use that as a barrier method when changing diapers. So what would happen is they would sprinkle that powder on baby. Baby would be crying because they were upset about getting their diaper changed. Baby would then inhale some of that talcum powder, and then it would lead to aspiration pneumonia. Okay. Of course, you also get concerned about babies laying flat on their back while they're feeding, getting aspiration, or having risk for aspiration because of their feeding. So making sure you're teaching parents to kind of elevate babes when they're feeding them. Infants, as they're starting to eat at the table with you in their high chair, making sure that they're sitting as upright as they can to reduce their risks of aspiration as well, can be really important in teaching these parents in order to prevent aspiration pneumonia. But the most common one we used to see was with the talcum powder or baby powder of any form. Doesn't have to be specifically talcum powder, but could potentially be a risk. Anything that aerosolizes, okay, that the kiddo's inhaling. Okay, foreign body aspiration. This is very common. Think about how kids are learning about their environment in that toddlerhood phase, oral phase of development, according to Freud, is where they're at. So very common that kids see something shiny on the ground and they pick it up and they put it in their mouth to kind of figure out, how it feels and what it is. Another common spot for kids to put objects are the nose and the ears. I've had 2 patients in the last 6 months that have put little rocks in their ears. And they're right in this age range, 2 to 3. So very common. Of course, if they're ingesting it, it's a lot more risky potentially on what they're ingesting. Okay. So a lot of times what you see done, if it's something metallic that will show up on an x-ray, a lot of times an x-ray will be done to see where at in the GI tract, or, in the nasal cavity, kind of where that object is. Button batteries get really concerning because, they're small enough that they can pass through and not really obstruct areas, but the concern is that as that hits your stomach acid, starts dissolving, and the acid within that battery can definitely be really corrosive to the lining of the stomach and the intestines. So that's really concerning. That requires surgery to remove usually. Sometimes they can go in endoscopically and remove these items, but a lot of times they have to have surgery. Hot dogs, peanuts, those popcorn, those are all choking hazards to younger children. But what can happen is they can kind of partially aspirate these into their lungs. Okay. So then what has to happen usually with those is they go in with the scope and pull those objects out. Okay. A lot of times these kids, because of the foreign body aspiration, will also be on some sort of antibiotic. Okay, especially if it goes into the lung piece. Okay. So post-operatively nursing care for kids with foreign body aspiration, you would do your routine post-op stuff. If they do not have to have an operation, say they ingested, a penny, or a small circular object that should go through their GI tract fine, make sure you tell parents that they need to be checking diapers or checking their stools of their older kiddos, if they're going potty on the potty, to make sure that that object is being passed without any issues. Okay. Okay, pertussis, whooping cough. So this is caused by Bordetella pertussis. Most often it happens in kids that are unimmunized against whooping cough. So whooping cough is included in the DTaP vaccine and the Tdap vaccine. That's the P part of the Tdap or DTaP vaccine covers for whooping cough. It used to be that adults were not vaccinated for whooping cough. When they got their routine tetanus vaccines, they would just get just the tetanus coverage, tetanus and diphtheria coverage, but they did not get any coverage for whooping cough. So we have gone away from that now as cases of whooping cough have begun to become more prominent. So now adults get the Tdap just like older adolescents get as well. That has whooping coverage, whooping cough coverage in it. Okay, it's very contagious, very, very contagious. It's really risky for young infants because what happens is they get to coughing that they become apneic. Older kids, you'll see them coughing so hard that they're throwing up while coughing. Usually happens during spring and summer. Okay. What's important to teach parents is to vaccinate these kids. If somebody in the home has had whooping cough, then that child needs to be treated. If somebody outside the home they know have been exposed to pertussis, if they're high risk for complications, then they should be getting a prophylactic azithromycin. Okay, so it's treated with azithromycin most commonly. Okay, smoke inhalation injury, of course, it depends on the nature of the inhalation injury. Usually what's going to be done is first, obviously, remove this patient from the smoke area or wherever they're having the smoke inhalation occur. Usually, initially, it's kind of local injury to the tissues, but it can progress then from, the lungs, the nasal cavity, down the trachea and into the lungs with burns. So then it starts affecting multiple systems. Humidified oxygen is what's going to be provided to these kiddos. And then managing the burns and post-admission things that you should be doing. So they may need, grafts and all of that if it was from a fire. Okay. So environmental toxins, specifically from tobacco smoke. Passive is secondhand smoke. So this is probably the most common in children form of smoke. Now they're even talking about third hand smoke. So secondhand smoke is, they're not the one smoking, but they're around a parent who is smoking around them. So this can cause kids to be more at risk for upper respiratory illnesses, lower respiratory illnesses, asthma, allergies. It can affect their growth even. Of course, if mom is smoking while pregnant, that leads to lower birth rate, increased risk for SIDS. Tobacco smoke is still a pretty large issue. Now it's kind of moved from tobacco as in cigarette smoke to vaping, vapors that, we don't really know what all chemicals are in these vapes. So I think, in the next few years, we'll probably be figuring out the risk of all of those. But tobacco smoke is still a fairly common issue. Okay. Obviously, managing care in these kids is talking with the parents about smoking cessation. Okay. Of course, if their kiddo has asthma or something like that, you'll also need to talk with the parent about how to manage the asthma, but make sure you talk with them about how they're smoking, even if they're smoking outside and coming back inside, that's still exposing that kiddo with asthma to smoke, which is going to worsen their prognosis. Okay, cystic fibrosis. This is an inherited disorder. So it's a genetic disorder from parents. It causes severe damage to the lungs, the digestive tract. Okay, it causes mucus and sweat and digestive juices to become more thick and gunky. Okay, so it kind of plugs up the lungs and leads to more frequent lung infections, resulting in pneumonia or bronchitis. A lot of times these kids are going to be consistently coughing. They're going to have really salty tasting skin because they're chloride, sweating out that chloride through their skin, wheezing, shortness of breath. They're going to have really greasy, stinky stools because of all the digestive mucus and gunk that comes out in their stools. Okay. Steraturia is another term for their types of stools that they have. These kids are going to have poor weight gain and poor growth, even though they may be eating well. Okay. Diagnosis of CF is a sweat test. Like I said, they check the chloride levels in your sweat, and it will come back that it's high in levels of chloride. And that is how they diagnose CF. Also, now on most newborn metabolic screening panels, they are testing for the cystic fibrosis gene. So fairly early on, within the first week or so, that can come back positive as well. Treatment for CF, kids will need antibiotics more often to prevent and treat illnesses, especially respiratory illnesses in the lungs. They're going to need medicines that thin their mucus, okay, and makes it easier for them to cough up that mucus and get it out of their lungs, okay. So they will be doing special things like chest physiotherapy, so those vibrating chest, it's like a vest that kids put on, and then it hooks up to a machine that kind of vibrates, and it breaks up anything that's accumulating in their lungs to allow them to more easily be able to cough that up and clear the mucus from their lungs. In littler kids, chest PT will look like a little cup that you can kind of hit on the back of the kiddo's lungs to break things up that way as well. Okay. With CF, they're going to have pancreatic insufficiency. So their pancreatic enzymes will need to be given to help absorb their nutrients. Okay, so that way they're not having so many stools and just totally getting rid of that nutrients. You cannot crush or chew the pancreatic enzymes because of the type of beads. They're enteric-coated beads. You can open it up, the capsule, and sprinkle it onto food. If you're doing the powder forms, you have to be sure you're talking with parents about rinsing their mouth afterwards. And then that dosage will have to be adjusted often to make sure that that kiddo is growing in a normal growth pattern. Okay. These kids will also be on bronchodilators, so they'll be on inhaled corticosteroids. Sometimes they'll be on alpha adrenergic blockers, so like things like albuterol. Sometimes they're on nebulizers. Sometimes they just do the inhalers. Sometimes they have to do nebulized or aerosolized antibiotic treatments. Sometimes they have to do home IV antibiotics. So, I mean, there's just a variety of things that go along with CF. Also, these kids will need to be in physical therapy to encourage their exercise as well. In regards to managing their GI problems that you see with CF, like I said, the pancreatic enzymes will need to be done to help them absorb as much as they can of those fat-soluble vitamins. High protein, high calorie diet, sometimes as much as 150% of their daily recommended allowance is what they need to intake. Okay. Managing the potential risk of an ileus by making sure that they're, up and moving routinely. Reducing the risk of rectal prolapse. So talking with parents about, not having these kids strain when they're trying to have a bowel movement. And then a lot of times they'll also have chronic acid reflux. So managing that with a PPI, so a proton pump inhibitor, or an H2 histamine blocker to help with their acid reduction. Also, if they aren't taking their pancreatic enzymes like they need to be, then a lot of times what you'll see progress is diabetes mellitus, okay, because of pancreatic fibrosis that happens, okay. Sweat gland dysfunction, like I said, they're sweating out a lot of chloride, so you can see sweat gland dysfunction occur, failure to thrive because they can't grow based off their nutritional needs, or weight loss despite an increased appetite. So this would be reasons why they would need to see an endocrinologist. Pregnancy. So if you have CF, you're at high risk for diabetes. And then as your cystic fibrosis worsens, or as you get older and your cystic fibrosis continues, if you become pregnant, it's going to be harder for you to breathe and to manage your nutrition and your liver function throughout your pregnancy. So it's likely that you will have diabetes during your pregnancy if you have CF. Also, it's more difficult for women with CF to become pregnant, okay? Pregnancy can be achieved, and some women can have normal pregnancy, but, sometimes there's a risk with infertility too for women who have CF, but with men who have cystic fibrosis, they are sterile until 1 year after having bilateral lung transplant. So men with CF will not be able to conceive until after a year after they've had a lung transplant. Okay. All right, sleep apnea. There's partial or complete obstruction of the upper airway that then disrupts respirations during sleep. What you can see is frequent snoring, pauses in breathing, so apnea, gasping or choking when they're kind of waking up in that lighter period of sleep, disturbed sleep, so they're, thrashing around, really restless. You can see secondary enuresis, so you can see urinary accidents during bedtime because of sleep apnea, daytime sleepiness, and behavioral problems during the day because they're not getting good restful sleep because of their sleep apnea. So it's diagnosed with a sleep study. Usually what is done for treatment is they remove tonsils and adenoids, or sometimes they just remove adenoids. It just kind of depends on what the cause of the sleep apnea is. If it's mostly because the adenoid is enlarged, then they will just remove the adenoids. If it's mostly because the tonsils are enlarged, they'll remove those. But a lot of kids wind up getting adenoids and tonsils removed. If they remove tonsils and adenoids and the snoring improves and the sleeping is improved and we're not having those behaviors, then you might not have to have your kiddo have a CPAP or BiPAP machine to aid in their sleeping. But if it continues after having that intervention, then they will need a CPAP or a BiPAP machine. Okay, the earlier you detect sleep apnea, the better. Okay. And then educating and counseling parents on what sort of things to watch for. And of course, making sure that they're continuing to abide by their CPAP or BiPAP rules, having their kiddo wear that. Okay. Okay, acute respiratory distress syndrome. So this is an acute lung injury. It is respiratory distress and hypoxia, so low oxygen, within 72 hours after a serious injury or surgery, usually caused from sepsis, drug overdose, near drowning, or some sort of trauma. And it's also referred to as ARDS. Okay. So pathophys of ARDS, it depends on the reason why it started. So if it's sepsis, your body gets so prone to fighting the infection that eventually your body stops compensating due to that infection, and you have respiratory deterioration that progresses to failure potentially. These kids need to be intubated. Prognosis, mortality is still really high in kids with ARDS. Usually kids can compensate for quite a while, and then as soon as they stop compensating, they deteriorate very quickly. Nursing care, kids with ARDS are going to be in the ICU. A lot of them are going to wind up on ECMO, which is what you're seeing here, which is a machine essentially that acts as their lungs and oxygenates their blood and returns it back to their body oxygenated. Okay. Okay, CPR. Just like with adults, CPR is required, if the kiddo's without a pulse or has cardiac arrest, or usually with kids, it's respiratory driven. Okay, so usually the reason why they become unresponsive is because of a respiratory reason. Okay, family should stay with the child during a CPR code. Okay, if the parents want to leave the child's side, somebody should stay with them if you have the ability to do that. Continue to provide continuous updates. If the code is a really lengthy one and the effects from that code are not going to be beneficial for that child, making sure that that provider is talking with the parents and the family about potential long-term outcomes for the child post resuscitation. Okay. And of course, we follow the American Heart Association resuscitation protocols. So CPR, usually in a hospital setting, you're going to have more than enough people to help you out with a code. But if you're in the school setting or you're in, a clinic, you might not have as many hands. So it might be you doing, the compressions and the breathing, and, getting the AED and all of that. So making sure you guys are all well aware of your CPR guidelines. Okay. Okay. Asthma. So this is inflammation of the airways. Symptoms are going to be recurring for asthma. So every time they become ill with an upper respiratory illness or a lower respiratory illness, or they come in contact with an allergen that causes kind of an hyperresponsiveness of the bronchi. So you'll see like a bronchospasm happen. And usually that's in the form of cough, 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 and then wheezing. Okay. They can get limited airflow in. Okay. And then as they breathe out, you hear that expiratory wheezing. Okay. And this is inflammation chronically of the bronchioles. So those bigger airway. Okay, diagnosing asthma, PFTs, like I said, allergies a lot of times go along with asthma. So skin testing for allergens. Sometimes some allergists do blood testing. The skin testing is more accurate. Managing their allergies will help them to manage their asthma. So I usually always talk with patients about that, making sure that as they're doing their their inhalers, that they're using spacers, so they can absorb and inhale all of that medication the way that they need to. This is a PFT, an example of one type of PFT that kids will do. Okay, the goal is to continue to allow kids with asthma to maintain their normal daily activities. Okay, and to prevent exacerbations. So usually what is beneficial for parents to be aware of is as soon as their kiddo has an upper respiratory illness and they start having that cough, 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 or that wheezy sound, they need to be doing their rescue inhaler routinely, or nebulizer. So albuterol routinely every 4 hours for the first couple of days of illness, and then every 4 hours as needed from there. Okay. Of course, making sure that they're up to date on all of their vaccines too can be helpful with asthma. Making sure that they're getting a flu shot so that way they're not getting influenza, which can, be more risky for kids with asthma. Long-term control medications, so they might be on daily inhaled corticosteroids, metered dose inhalers. That's what this little 2 or 3 year old probably here has. So metered dose inhaler, that means you push it down and it gives you one puff or one dose. So that's pretty common now with kids. Even younger kids, they can do those metered dose inhalers just by using the mask, holding it up more quickly than sitting with a nebulized solution. So it has become more popular. Quick relief medication, that is your albuterol. Okay. And then, like I said, inhaled corticosteroids, so something like budesonide or Symbicort or Pulmicort would be more of a daily long-term control inhaler nebulized solution. Okay. Status as medicus, this is a medical emergency. These kids need to be seen in the ER right away. This is something that happens. They do their routine rescue inhaler and nothing is helping. So they start with respiratory failure, and then of course if respiratory failure interventions do not work, then death occurs. Okay, usually concurrent infection. So usually they have some sort of infection going on when they're having the status asthmaticus. Okay. So when these kids come into the ER, usually what happens is no matter what you're doing, trying to manage their asthma, nothing seeming to help. So the goal is to improve their ventilation. So a lot of times they have to be intubated. And then a lot of times they need some pharmacologic interventions as well, like steroids and inhaled steroids and fluids and all sorts of things. Okay. I'm gonna stop my share. We'll go and do the Cahoots. Sorry, it's taking forever to load here. Make sure you guys are staying in your camera view, please. Okay, I'm gonna hit start on this and then I'll share my screen. Okay. Looks like you guys are able to see that now. Okay, we'll go ahead and get started here. Majority of upper respiratory infections are caused by Streptococcus pneumoniae, Maxillus cardialis, viruses, Haemophilus influenza. Viruses, yep, good. The other three are bacterial, okay? Maxillella catarrhalis, you'll see that for pneumonias as a type of pneumonia, but that's bacterial too. Good. Okay, you walk into a 6-year-old child's room and you find them not breathing and they do not wake up. Are you going to leave and call for help? Are you going to administer 2 deep breaths, take vitals, or start chest compressions? Yes, start chest compressions right away. That's the first thing you do. Do a round of chest compressions. And then if you're still by yourself after 2 minutes, you do your chest compressions and you're deep breathing, then you can step out in the hallway and get help from somebody. Okay, good. Okay, multiple select. What are some signs and symptoms that smaller children may exhibit if they have a respiratory infection? Fever, vomiting, poor appetite, or abdominal pain? All of those. Yep. So why would you think some kids say that they have abdominal pain with the respiratory infection? What could be going on there?
The mucus is usually acidic.
Uh-huh. Yeah, so they're swallowing mucus. What else?
Using accessory muscles, maybe coughing, makes
Yeah.
it sore.
Yep. Good. So I've had some kids tell me that they have belly pain and I do a chest x-ray and they have pneumonia. And it's usually on the same side that they're having their belly pain. The other thing too is some kids will say that they have back pain, like flank pain, kind of like some kids will have with UTIs type symptoms, but they'll have pneumonia too. Okay. Good. And the vomiting might be because they're coughing so hard they're throwing up too, right? Or also from the mucus. Good. Okay, multiple select. What do you look for when assessing respiratory function? Rate, depth, labored breathing, ease of breathing. All of those. Yep. Good. So, what would, if an infant was having respiratory distress, what sort of things would you see?
Retractions.
Yeah. Where can retractions be?
You can see them like by their collarbones and their belly.
Yeah, they can be belly breathing.
Nasal flaring.
Yep. What else? Intracostal, so between the ribs, right? What about tracheal tugging? Right? So you'll kind of see like a pull kind of in the area of their trachea. Grunting, right? Those can all be kinds of signs of labored breathing. Good. Have any of you guys in clinical seen any respiratory stuff yet with kids? No, not yet. Have you started your clinicals yet?
Don't have clinicals until December.
Oh, okay, darn it. Well,
I have
that'll be a
mine.
good time. You guys will be seeing a lot of respiratory stuff in December, so you'll have good knowledge probably of respiratory illnesses at that point. What would you look for after a child has had a tonsillectomy? Severe pain, unable to drink fluids, swallowing more than usual, or high fever? Yeah, swallowing more than usual because you're concerned that they're bleeding, right? That those scabs have kind of come off of where the tonsils were, and now they're bleeding from that area. Good. Also, if kids are having significant pain, they're not going to be drinking like they should. So making sure that you're keeping an eye on their hydration status too, and letting parents know that that should be something that they're watching for too. But the emergency case is the swallowing. Okay, multiple select. Nursing care for a child's status post tonsillectomy include frequent pain medications, spicy food, gum, an ice bag to the neck. Yep, good. Frequent pain meds, gum, and gum is for what? The ear pain, right? That can come along with that. And then an ice bag to the neck, especially initially after surgery, because they're going to be pretty swollen. Okay. No spicy foods. They would appreciate that you did not give them spicy or salty or acidic foods. Okay. So if they're kids that usually eat those sort of things, you're going to have to work with parents on finding alternatives that they can eat until they're all healed up about 2 weeks after. Good. Okay, another multiple select. What signs and symptoms would you see in a child with otitis media? Ear pain, loss of appetite, purulent ear drainage, always a high fever. Ear pain, loss of appetite, purulent ear drainage. Okay, now you won't always see purulent ear drainage out of the ear. Okay, if it's coming out of the ear, that means that they have perforated their eardrum from their ear infection, or they have ear tubes and it's doing what it's supposed to and letting that drainage come out instead of stay back behind their TM. Okay. Now, when you look in a kiddo's ear, you'll see kind of a purulent color. So it'll look more kind of white color, dull looking. It won't be nice and shiny like it usually is if they have an ear infection, and it will be red. Okay. You don't always have high fevers. Usually with ear infections, the highest fever related to solely an ear infection I've ever seen is like 102.5. Okay. So usually not super high fevers with ear infections. They might have some fever, but not usually really high. Okay. And because of that pressure of that fluid in their ear, they're going to have kind of ear pain that kind of radiates into their jaw. And a lot of times you'll see kids not want to eat because of it. They're going to not sleep well because when they lay down, there's going to be a lot more pressure back behind that TM because of the fluid. Okay, good. Okay, multiple select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Asthma, bronchitis, tracheobronchitis, or pneumonia? Okay, so tracheobronchitis and bronchitis. Okay. With pneumonia, what sort of cough would they have?
Wet or secretion.
Yeah, wet, not dry. Okay. Good. The monthly immunization for RSV is Hib, Humira, Synagis, Indocin. Synagis. Yep. Good. Your books will have to update soon because Nursinimab is going to be taking over and Synagis will no longer be available. Okay, a 4-year-old child has been taking medications for asthma. The child is still wheezing. What information is important? The child has a fever. They're using their MDI without a spacer. They're taking aerosols, or they have a loose cough, which is the most important for a kiddo with asthma. Yes, they're using their inhaler without a spacer. Why would that be important?
The appropriate dosing is being administered or inhaled.
Right, yeah, they're not inhaling all of their medication, right? I mean, even adults, they've done studies now on adults who use spacers and who do not use spacers, and the management is a lot better if the adult uses a spacer with their inhaler as well. So kids definitely can't inhale all of the inhaler medication that they need to. So always a spacer with an inhaler. Good. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Respiratory rate of 25 and a pulse rate of 108, abdominal breathing and a pulse of 100, pulse ox of 95% on room air, substernal retractions, and restlessness. Yes, good. Substernal retraction and restlessness. Good. 95% on room air, that's still within normal range, right? And then belly breathing, but not tachycardic. That's not super concerning. But if kids continue belly breathing and they become more have a higher pulse rate, then they're progressing towards respiratory distress. Good. Signs and symptoms of asthma include all except initial hacking cough, shortness of breath, wheezing, shortened expiratory phase. Yes, shortened expiratory phase. What is it with asthma? What happens with their expiratory phase?
It's prolonged.
Yes, good. That's why you hear that wheezing. Okay, expiratory wheezing. Good. What should you not do to children diagnosed with croup and epiglottitis? Soft tissue x-ray, parent holding, IV placement, looking in the oral pharynx. Okay. You should not look at the oral pharynx because what happens if you try to, use your tongue depressor and look back to the back of their throat, what can happen is you can cause a spasm to happen, a bronchospasm, and their epiglottitis can interfere with their airway more quickly. Okay. Good. Okay, nursing interventions with a patient with epiglottitis would include having an intubation tray at the bedside, check for strep pharyngitis, suction the oral airway, or encourage warm tea. Yep, good. Have an intubation tray at the bedside. Good. Hannah, I'm just seeing your ceiling. Can you come on camera, please? Thank you. Which triad suggests epiglottitis? sore throat, difficulty swallowing, drooling, polydipsia, polyphagia, polyuria, muffled heart tones, jugular vein distension, pulseless paradoxis, or hypertension, bradycardia, altered breathing. Yes, sore throat, difficulty swallowing, and drooling. Good. Multiple select treatment for infectious mononucleosis. Antibiotics, rest, no contact sports, antipyretics. What do you do for mono? Okay, mono is what? Bacterial or viral?
Viral.
Viral. Do we remember which virus usually causes it? Epstein-Barr virus. Okay. So with viruses, antibiotics will not be helpful. So rest. No contact sports. Do we remember why no contact sports?
The
Splenomegaly.
Yeah,
Sorry, Haley. I couldn't hear what you said.
Was it the hepatomegaly you said?
And splenomegaly. Yep.
Okay.
Because those are enlarged. The contact, if they were on a contact sport and they got hit, they would be at more risk for, laceration of the liver or the spleen. So yeah, that's why no contact sports, and then antipyretics because they'll probably have fever, especially initially. Okay, multiple select. When doing an admission of an infant with a low-grade fever and loose cough, what information is important? ABGAR scores at birth, highest fever recorded, immunization status, medications, doses given, and times. Yes, highest fever that they've had with this illness. Okay. Their vaccination status, so you can see if you need to be concerned about Haemophilus influenza or strep pneumoniae or some of those things that we can vaccinate for if they're not up to date on their vaccines. And then medications that they've been given and what time they were given those medications. And how much parents gave of those medications. Like I have had parents tell me that they gave them Tylenol and it didn't help their fever at all, or they gave them Motrin and it didn't help their fever come down at all. But if you ask them how much they gave, maybe they didn't give them quite enough to help with the fever. So making sure you know how much they're being given too, so you can know if they're getting an adequate dose. How is cystic fibrosis identified? Breathalyzer, analysis of blood smears, newborn screening and sweat tests, or stool testing? Newborn screening and sweat tests. Okay, that's how they diagnose CF. Good. Multiple select. What is included in the plan of care for a child with cystic fibrosis? Aggressive chest physiotherapy, high protein diet, pancreatic enzymes with meals, or low sodium diet? Yep, good. Aggressive chest physiotherapy to break up some of that mucus in their lungs that gets really thick. That puts them at increased risk for pneumonia and respiratory illnesses. high protein diets. That way they can get enough protein for their nutrition or to grow adequately. And then pancreatic enzymes, those need to be given with meals so that way they can absorb their fat soluble vitamins. Okay. Good. What medication would you hold for an infant that is vomiting and vital signs are temp 98, pulse 88, respiratory 32? Oh, this is not a respiratory question. Hydralazine, metoprolol, digoxin, or enalapril? Okay, so dig toxicity in infants can simply just be vomiting. Okay, and if you look at this infant's pulse rate, 88, that's pretty low for an infant. I mean, it's within normal range for some older infants, but for most infants, that's pretty low. So I would be cautious on giving dig with a kiddo that's an infant with a pulse rate of 88. Okay, but vomiting is the piece there that you should be looking at as well. Good. Which information is most important when rheumatic fever is suspected? So a fever that started 3 days ago, a recent episode of pharyngitis, a recent URI, or vomiting for 2 days. Okay, so a recent episode of pharyngitis. So what goes along with rheumatic fever? What bacteria do
Strep.
we have to think about? Yes, group A beta hemolytic strep specifically. All the other beta hemolytic streps, there's group C, there's group G, all of those, you don't worry about rheumatic fever. Okay, group A strep specifically, which most commonly causes sore throat. Okay, so if you know a kiddo who has suspected rheumatic fever, you should be asking them if they've had a recent strep test or sore throat. Okay, good. Signs of shock in children include all of the following except altered mental status, poor capillary refill, hypertension, tachycardia. Hypertension. Okay, I feel like these are kind of getting into cardiac questions now. Yeah, let's stop this and we'll get into cardiac. Are you guys good with that? Yeah, okay. Okay, let me share my screen again here. Okay, you guys should be seeing the PowerPoint again now. Okay, sorry, I have to go all the way through. Okay, cardiac dysfunction in pediatrics. So what you get concerned, or what's most common you hear about in pediatrics, is congenital. So that means that it's present at birth. Okay. So as soon as that kiddo is born, they have a congenital cardiac defect. Usually it's anatomic. So it is something is abnormal with the anatomy of the heart. Okay. Now, acquired cardiac defect is there's something that caused that to happen. Now, it may be also present at birth, but it's from a disease process. So mom had an infection while she was pregnant that caused that child to have that specific cardiac defect. Or there's an autoimmune response. So that would be like rheumatic fever, okay, where there's that vegetation on the heart valve from strep. Okay, environmental factors. The other autoimmune response issue that can cause cardiac issues is Kawasaki's disease. Family tendencies to have cardiac defects. So like your arrhythmias and things like that. But if there's something anatomically that is there at birth, then it's a congenital heart defect. Okay. So, oh, hang on, get some. Okay, so normal circulation pattern, okay? It's gonna go in to the right atria, right ventricle, out to the lungs through the pulmonary arteries, okay? Back from the lungs through the pulmonary veins, into the left atria, to the left ventricle. Oh, sorry, I lost it. To the left ventricle, and then out to the body through the aorta. Okay. So that's normal circulation. I'll come back through the vena cava to the right atria. Okay. So keep that in mind, normal circulation. Okay. So for your cardiovascular dysfunction, what you're going to see on exam, if let's say this kiddo had a congenital heart defect that wasn't identified on ultrasound, some of them can't be identified on ultrasound. Most of them now are getting to be identified on ultrasound, but this kiddo came in, they're a week old, all of a sudden they're not feeding well, they're breathing really hard and fast when they're trying to eat. They're not gaining weight, they're behind on their developmental milestones, and then they have a significant history of cardiac defects in their family. Okay. The poor weight gain piece specifically is because they're not getting adequate oxygenation. Okay, so they're having diminished energy, especially if they're breastfeeding. So babies that are breastfeeding are going to have more difficulty gaining weight than babies who are bottle fed, just because it takes more energy to breastfeed. Okay. Okay, so you're inspecting these kids, so you're looking at them, okay? You're going to notice some cyanosis a lot of times if they're having cardiac dysfunction. You might notice chest deformities. So you might notice, a convex or a concave chest. You might notice unusual pulsations on their chest. Okay, clubbing of the nails of the fingers. Okay. Might hear a murmur when you're listening. Okay. You're going to want to palpate their chest, their abdomen. Some murmurs are so significant that you can actually feel the thrill is one that you can feel, on their chest. Checking their pulses. Is there a difference in the pulses, upper to lower body? Is there a difference in your blood pressure, upper to lower extremities? Thinking about the heart rate, the rhythm. Is it regular? Is it irregular? Are they tachycardic? Are they bradycardic? Do they have a clicking noise of a murmur? Is it a mechanical sound? Is it a swooshing kind of noise? So thinking of all those things while you're listening. Okay. Cardiovascular dysfunction, usually first thing that is done is an EKG or an ECG, electrocardiogram, and then an echocardiogram. So electrocardiogram looks at the electrical activity of the heart and that pathway. The echo looks at the actual functioning of the heart. Okay, so that's an ultrasound that's utilized in the echo, whereas the EKG is just with the patches. Okay. Sometimes there's still concerns that there is an abnormality that maybe can't fully be determined with an echo or an EKG. So then they go in and they do a diagnostic cardiac cath. Usually in children, they go in through the femoral arteries. Okay. And then sometimes if they already know that there's a defect that they can repair via cardiac catheterization, they just go in an interventional cardiac cath and they'll do that repair. So they'll do the ballooning or an ablation or something like that. Okay. And the electrophysiology test, that's like stress test. So they're getting a, physiologic demand while they're doing some sort of activity. They have an EKG attached to them. Okay. So nursing care after cardiac catheterization, pre-op wise, of course, NPO, making sure that they've stopped anything that can prolong their bleeding. Vital signs are stable, things like that prior to them having the cardiac cath. Okay. Post-procedure, post-operatively, you're going to be getting frequent vital signs. You're going to be checking pulses, checking the temperature of the extremity that the cath was performed through, looking at the dressing, making sure that fluids are being intaken, and that blood glucose levels are stable. Okay. The biggest risk is hemorrhage from the catheter site, because they go in through a big artery, usually like the femoral artery. Okay. Pressure, you'll have to hold pressure on these dressings usually for a period of time. Kids will also have to lay flat, usually for a period of time as well, depending on where they went in for the cardiac cath. Okay, congenital heart disease. This happens in about 5 to 8 per 1,000 live births, which is actually fairly significant. Okay, 2 or 3 of these cases can be symptomatic in the first year of life. It's the most common cause of death in the first year of life, second only to prematurity. Okay. VSD or ventricular septal defect is the most common anomaly. And it's more often that they also have some sort of syndrome or other anomaly like trisomy 21, 13, or 18. And you can see these babies have both have had heart surgery. Okay, so there's altered hemodynamics potentially in congenital heart defects. So depending on the type of defect, they can be acyanotic or cyanotic lesions. So cyanotic lesions are going to be your blue babies, okay? So your blood flows from the area of highest pressure to lower pressure, okay? And it's going to take whichever the path of least resistance is. So if you have an opening between your left ventricle and your right ventricle, which direction is the blood going to try to go? Okay, let me ask this. Which area has the highest pressure? usually.
The left ventricle?
Left ventricle. So if you have a hole between the right and the left ventricle, where is blood going to want to shunt to?
The right ventricle?
The right ventricle. And then your blood's just going to continue to circulate to your lungs, right? Because it's shunting from the left side to the right side. So if it's shunting from the left to the right, that is going to be an acyanotic lesion because it's continuing to circulate back to the lungs. So it's getting that oxygenated blood. Okay. If you're shunting right to left, that's going to be a cyanotic lesion. Okay. So this is kind of another way to say it. Increased pulmonary blood flow or obstruction to the blood flow from the ventricles. These are going to be your acyanotic lesions. So their oxygenation is going to be essentially unaffected in these kids with these defects. Okay, so your ASD, your VSD, your PDA, your AV canals, coarctations, aortic stenosis, pulmonic valve stenosis. Those are all going to be acyanotic lesions. Cyanotic lesions, that means decreased pulmonary blood flow. Okay, so it's not going to the lungs like it needs to, or if it is going to the lungs, you're having a lot of mixing. Okay, so your cyanotic lesions are going to be your tetralogy of Fallot, tricuspid atresia, transposition of the great arteries. So there's that flip. Total anomalous pulmonary venous return, trunctus arteriosus, and hypoplastic left heart. Okay. Okay, we're going to talk about PDA. This is how your body in utero circulates your blood through your heart. Okay, because it doesn't need to go to the lungs while you're in utero, right? So shortly after birth, this opening closes. Okay. So where the opening is between the aorta and your pulmonary artery. Then after birth, usually within 24 hours, this should close. If it doesn't close, what you're going to hear is a loud, like washing machine. You know, when your washing machine is agitating your clothes, that's what you're going to hear for a murmur. They're going to have wide pulse pressure. Okay. So that means the blood pressure will be like, there'll be a large discrepancy between your systolic and your diastolic. Okay. After the PDA closes, then the blood pressure will normalize and your murmur will go away. Okay. Okay. Now, in some other defects, you have to keep that PDA open for the baby to continue to get oxygenated blood. So transposition of the great arteries and tricuspid atresia, those are two examples that the PDA has to stay open. They keep the PDA open with prostaglandins, okay, like indomethacin. Oh, excuse me. They keep it open with prostaglandins. You can close it with indomethacin. Sorry, I said that incorrectly. If the indomethacin after 3 doses does not close that PDA, then they have to have a patch from surgery. Okay. But if they have a cardiac defect like transposition of the great arteries or tricuspid atresia, that PDA needs to stay open with prostaglandin. Okay. So the defects that increase pulmonary blood flow, or another way to say it is your acyanotic lesions, are going to be, so first we're going to look at VSD and ASD. We just talked about PDA, so that's also an acyanotic lesion, okay, because the blood flow is circulating more often to your lungs. Okay. So ASD is an abnormal connection between the two sides of the heart. VSD, same thing. So your ASD is going to be the abnormal openings between the atrial, both sides of the atrium, and your VSD is going to be the opening in the septum between the two ventricles. Okay. You're going to have decreased systemic blood flow. You're going to have increased blood volume on the right side because your blood is going to shunt from the left side of the heart to the right side of the heart. Okay. Is everyone understanding so far? Not losing anyone yet? Okay. So this is just kind of another way to show that shunting. Left side to right side is going to be acyanotic. Okay. Your obstructive defects. So coarctation is a narrowing. Okay. So here's your aorta. It should be a big open pathway here. And then here's a coarctation of your aorta. So a narrowing of that aorta. Okay. Stenosis is also a narrowing. Okay. So coarctation of the aorta, aortic stenosis of that valve, that opening is stenotic. Okay. And pulmonary stenosis or pulmonic stenosis. Those are all obstructive lesions or defects. Okay. So defects that cause decreased pulmonary blood flow. Okay, so you're getting an obstruction to the pulmonary blood flow because of an anatomic defect. Most common defect that's talked about is tetralogy of Fallot. Okay, because there's a lot of defects within that defect. Okay, tricuspid atresia also is a defect that causes decreased pulmonary blood flow. Okay, so this is going to be your right to left shunting. Okay, transposition of the great arteries. This is when your aorta and your pulmonary arteries are swapped. Okay, so there's you can see here, it's kind of a lot of backflow. Your aorta is getting your oxygenated blood and taking that, or your unoxygenated blood, excuse me, and taking that to your body. Okay, there's a lot of blood mixing. Okay, hypoplastic left heart. This is essentially your left side of your heart does not function the way it should. So there's a lot of backflow to the right side. Okay, so it's not circulated out to the lungs and then out to the body like it should. It's just mixing. Okay. Congestive heart failure. So you're going to see similar type of signs with kids with congestive heart failure that you can see in adults. Okay. It can be right-sided failure or left-sided heart failure. Usually there are structural abnormalities with these kids. So you can kind of see the concaved chest. So that could be a sign potentially of a kiddo who's in congestive heart failure. Okay. The heart has an inability to pump the adequate amount of blood to circulate in the system. So impaired myocardial function can happen, pulmonary congestion, of course, that kind of wet rails that you can hear in the lungs can happen with congestive heart failure in kids, just like with adults. They're going to have more swelling, high blood pressure, all of that. Okay. It's diagnosed based off of their clinical findings. Okay. Management of congestive heart failure, of course, maintaining and improving that cardiac function, removing any excess fluid and sodium, so using diuretics, improving their cardiac function by using things like digoxin, okay, or those beta blockers, decreasing their cardiac demands, and improving their tissue oxygenation. Okay, your nursing care. So like I said, improving cardiac function did just typically what's going to be utilized. You have to do a 1 minute apical pulse. So you're listening with your stethoscope, counting for 1 whole minute, checking routine electrolytes, checking digoxin levels routinely. And like I said, in the CAHOOTS, vomiting can be the only early sign of toxicity in infants. So making sure you're monitoring that. Okay. You're wanting to look at decreasing cardiac demands, reducing respiratory distress. So some of these kids have to be on oxygenation because of that, because of their work of breathing, because of their defect and their reduced cardiac function. Okay. Family support is also going to be a part of what you're doing as a nurse. Hypoxia. So chronic hypoxia can lead to cyanosis, of course. So that bluing of the skin, clubbing of the fingernails. You can see that here, kind of that curved look to the nails, and polycythemia of the blood. Okay. When caring for the family and child who has cardiac defect, of course, you're going to have to work with the parents on educating them about their disorder that the child has and the disease that may come along with that diagnosis of the defect. Okay. Helping them manage illnesses from home. So that way, hopefully they're not having to come into the hospital or the clinic often and potentially be exposed to more illnesses. Okay. Getting them ready for invasive procedures like cardiac catheterizations, echoes, things like that. Okay. Post-op and discharge planning. Cardiac cath, we kind of already talked about this, so I'm not going to go, I'm not going to read you guys this page. Bacterial endocarditis, most commonly caused by strep, but also can be staph or fungal infections. If they have a history of bacterial endocarditis, which is an infection in the endocardium, before procedures, they'll need an antibiotic at least an hour before. Okay. Even like dental procedures, they need an antibiotic prior to that. Rheumatic fever or rheumatic heart disease. This is from group A beta hemolytic strep. This is how strep can look in a throat if it's really bad. It doesn't always have this exudate though on the tonsils, but a lot of times it does. So rheumatic fever can affect the joints, the skin, the brain, the heart, can cause chorea, which are like abnormal involuntary movements. Usually it's kind of like shoulder shrugging is usually what you kind of see with chorea. These kids will have to be on long-term prophylaxis of antibiotics. Usually penicillin is the choice for 5 to 10 years, depending on if there's valve damage. If there's valve involvement, then they will be on prophylactic penicillin for 10 years. Of course, if they're allergic to penicillin, then you pick another prophylactic antibiotic. Everything else can resolve other than valve damage. Hyperlipidemia or hypercholesterolemia. So this is excessive fatty lipids in the blood. Okay. Increased risk, of course, is obesity or high or poor nutrition, high calorie, high fat intake diets. So if these kids are on medications to reduce their cholesterol, of course, talking with them about routinely taking that and being compliant with that to reduce their risk of stroke and cardiac effects because of their high cholesterol. First preferred treatment, though, of high cholesterol is, of course, managing their weight and obesity So managing their nutrition. Cardiac dysrhythmias, so Brady dysrhythmias, that's going to be your slow rates. Your tachydysrhythmias are going to be your fast rate, heart rate. Your conjunction disturbances, this is your irregular heart rate. So this is where you're going through the pathway, the electronic pathway for your heartbeat. And you skip a portion of the pathway. That's going to be your conduction disturbances, like a PAC or a PVC. Okay, pulmonary artery hypertension. This is an elevation of pulmonary artery pressure. Okay, usually leads to right ventricular hypertrophy, usually because of a regurgitation through the valves. Okay. You usually see chest pain, lightheadedness, syncope, difficulty breathing with exercise. Okay, high blood pressure eventually. Cardiomyopathy. So you can see this heart is huge on this kid's x-ray. Usually a heart should be about, maybe half of the chest. This is taking up almost the entire chest on this x-ray. So usually familial or genetic cause. Sometimes infections can cause cardiomyopathies. Some flu viruses, they wondered about COVID causing some cardiomyopathies as well. And then sometimes metabolic abnormalities can lead kids more prone to cardiac myopathies. Heart transplants. Obviously, the biggest concern with any transplant, but specifically heart transplant, is rejection. So they'll be on long-term anti-rejection medications. Of course, long-term problems is as the kiddo grows, they might need another transplant, depending on the demand, the size of their heart and all of that. Okay. Chest tubes. Important things with chest tubes. I'll probably finish this page and then you guys can head out unless you want to continue. Medicating before you remove the chest tube, it can be really painful if you do not do that. So make sure you're medicating before removal. You take vital signs before removal. Make sure that that kiddo is still stable. You want to be honest and let them know that it can be more of a burning kind of sensation while you're pulling that out, but that it should stop shortly after the tube is removed. Some kiddos will have multiple chest tubes, but these need removed after drainage stops. Okay. Alrighty. You guys want to keep going here? We have, let's see, how many pages? We have about 10 slides left. Do you want to keep going? Yeah? No?
No.
Okay, well, if those of you want to hop, technically you've been here for your entire class, so if you want to hop off, you can. Otherwise, those of you that want to stay on, I'll just keep going, okay? If you need anything, let me know. I know it's a lot of information. Respiratory and cardiac in one day is a lot. I totally understand, but you also can't really talk about one without talking about the other kind of at the same time anatomically. So, like I said, if you guys want to hop off, you sure can. Otherwise, I'll finish up these last few pages. Okay. You guys should be able to see it again here. Oh my goodness. Okay. So systemic hypertension, essential means that there's no known cause. Secondary means that there's a identifiable cause. Usually the cause is a cardiac anomaly or renal anomaly or endocrine disorder. Okay. So in pediatrics, it's almost always secondary. And high blood pressure. You're going to treat it similarly to how you treat hypertension in adults. Some need medications. First line recommendation though is, increasing their activity and improving their nutrition. Okay, Kawasaki disease. So this is an autoimmune thing that happens. It's a systemic vasculitis. We don't really know why it happens with one kid versus another. Usually post-infectious, so usually they've had some sort of virus. And then what happens is they start to have this rash, head to toe, macular, kind of almost hive-like rash. They have conjunctivitis, so that redness, like they've had pink eye, they start having peeling skin. Sometimes their lymph nodes, or a lot of times their lymph nodes are swollen, cracked lips, their strawberry tongue, so their tongue, they'll stick it out at you and it literally looks like a strawberry is on their tongue. So this is a form of vasculitis. Usually in kids younger than 5, it's viral cause usually, but you're at an increased risk for coronary artery aneurysm. So these kids will need IVIG. Oh, here, this is that picture of the strawberry tongue. It's kind of hard to see in the picture, but that's also something you can have. But these kids will need intravenous gamma globulin or IVIG infusion. It will go, they might have to have multiple doses of it, but usually just one dose while they're in the hospital, and then they'll get high dose aspirin every 6 hours. Now, we almost never do aspirin in kids, right? Because of the risk of Reye syndrome, but the risk of these kids needing to be anticoagulated due to stroke risks with Kawasaki's is having them on aspirin is less risky than it is to risk not doing the aspirin and them having a stroke. Okay. Okay. Multi-system inflammatory disease. So this is an immune mediated injury after COVID specifically. So this is very similar to Kawasaki disease. Okay. These kids have to have a fever greater than 38 degrees Celsius for longer than 24 hours. Okay. Now with Kawasaki's, it's usually a longer fever greater than 24 hours. More like 72 hours with Kawasaki's. They'll have an elevated CRP, sed rate, fibrinogen, procalcitonin, D-dimer, ferritin, LDH, or IL-6. Okay, those are all inflammatory markers. So those are usually almost all elevated in MISC, which is multi-system inflammatory disorder or disease of children. Elevated neutrophils, low lymphocytes, and low albumin. These kids also have a recent history of COVID-19, usually within the last 4 weeks. Okay. And you've ruled out any other causes of their multi-system inflammatory disease. Okay. Your treatment's going to be IVIG, sometimes aspirin, depending on the effects. Okay. So this kiddo will look very similar to the kiddo with Kawasaki's. They may not have the strawberry tongue, but they're usually going to have a rash, fevers, elevated inflammatory markers. Okay. Shock. So we'll go in, compensated shock. So these kids their blood pressure is compensating, and then they become, eventually they progress to decompensated shock. So to where then they're progressing to anaphylaxis and septic shock. So we're going to talk about anaphylaxis. So this is a response to an allergen, causes bronchoconstriction, vasodilation, and then increased capillary permeability. It's a very abrupt onset of symptoms. Your goal is to stop your reaction to improve the circulation and ventilation. Obviously, prevention is the best approach. So avoiding those allergies that cause anaphylaxis. For example, a lot of people, we think of peanut allergies. Okay. So these kids will need to have epinephrine on hand. And that's what they'll be given to hopefully prevent their anaphylaxis from progressing. Septic shock. So this is an infection that triggers, an immune response. Okay. This causes, once again, vasodilation, increased capillary permeability, and then eventually death. Okay. The goal is to eliminate the infectious agent. Okay. Early stage of shock, and then progresses. Usually at first, they're normodynamic, so they're maintaining their blood pressure, and then they start to have low blood pressure, so then they become hypodynamic and they progress to later stages of shock that are harder to reverse. Okay. So maintaining their blood pressure, maintaining adequate oxygenation, and then giving them antibiotics to treat the infection. Okay, to keep them from progressing to that decompensated hypodynamic shock. Toxic shock syndrome. This is a rare condition caused from staph. Can cause multi-system organ failure. Same treatment as shock, so fluids. That's going to be your most common treatment of shock. Fluids, and then antibiotics potentially. And then your prevention for toxic shock syndrome, you hear it mostly with tampon use and leaving the tampons inserted for too lengthy of a time. Or not changing them routinely enough. So making sure you're educating teens about frequent tampon changing. Okay. Okay. Surgical closure of the PDA would result in which of the following?
Is it D?
Yes. Because it just keeps circulating that oxygenated blood back to the lungs instead of pushing it out to the body. Yep, good. Alrighty. I know that was a ton of information. So I'm sorry, your guys' heads are probably all spinning now. But, and I will say this exam is kind of a lot too. This next exam. So make sure you guys are studying, attend a live review session if you can. That's going to be something that's really beneficial to you. If you can't attend a live review session,